SRIP was all about how do you implement the projects, how do you collaborate with community providers. I think through the MACs, we've been able to put a structure in place with the workshops, the weekly status calls, that a level of trust is developed. People understand someone else's perspective.
Interventions are going to have to be delivered across the care continuum. So when we were looking for care team members, we looked for folks that were involved in the emergency room, in the hospital, in our primary care clinics, and also with community-based partners that are helping with care coordination services.
We had an opportunity to meet people who shared a common goal, which was, you don't get to do that often. So that was great, and we learned pertinent information to benefit our program. And we were also able to share our knowledge, to help other teams as well.
We were able to really brainstorm and look at what was available, what resources did we have, what did we need to create in order to accomplish some of the objectives that we had. It gave us the time and the format to be able to do that we normally wouldn't have if we were just going about our regular workday.
You can kind of compare, not competitively, but compare what your issues are. Some of them may be the same issues. Some of them have different solutions to the same issues.
We were able to come up with a process, such as now we have 2 Spanish-speaking AA groups that run here in the hospital every week. We actually connect them with a sponsor while they're here in the hospital still, and we've never done that before.
As an ER nurse and as the outcome programs coordinator, I never went outside of our ER. So this kind of allowed me to branch out and become partners with the community. And that made a huge difference.
So we were brought in to sort of provide the perspective of the homeless service provider and sort of help the hospital learn how to navigate that system. And then in turn, the hospital was able to help us with our patients navigate the hospital side in order to create better coordinated care for both entities.
The ability to know who the people in the community you need to reach out to, who could come here and meet with the individuals. I think before that was lacking. We knew the organizations were there, but who was our contact?
So now currently when a patient comes in that's somebody we may already be affiliated with, we are contacted so that we can come in and meet with them.
Usually when you think about performance improvement, you think about big projects. What Max brought to the picture was that small changes and processes can make huge differences. And I think that was the beauty of the Max program.
It focuses on what the individual needs and not trying to make the individual fit into a process, but having a process be available, and ready to service different types of scenarios.
Taking what I learned from the MAX series and then applying it to the other areas that I control, whether it's length of stay or readmission rates. So it's just it's been very valuable experience.
And we joke in the Army, 29-year Army veteran, that no plan survives first contact with the enemy. So you have to be adaptable, all right? And, they come with a plan around how we identify and then how we assess our patients, and it didn't work. And so then, kind of re-engineering that on the fly while still trying to make sure we're delivering the service, delivering care to the patient. And it was an interesting challenge, and one that they overcame and came up with a better product, a better process.
Really connect the dots and to understand our patients in a broader sense and realize what are the specific challenges they have on a daily basis and how as a community we can really band together and provide leadership as an organization to steward our patients to higher quality care and overall improved outcomes as well as better quality of life.